Hello, my name is Cristal Rivera, and today I want to talk to you about hyperemesis gravidarum. Hyperemesis gravidarum is the most severe form of nausea and vomiting in pregnancy. It is characterized by persistent nausea and vomiting not related to other causes. Hyperemesis may cause volume depletion, electrolyte and acid-base imbalance, nutritional deficiencies, and even death. Severe hyperemesis requiring hospitalization occurs in about 0.3 to 3% of all pregnancies. Some of the signs and symptoms we may see with hyperemesis include severe nausea and vomiting, weight loss of at least 5% of pre-pregnancy weight, volume depletion, ketonuria or ketonemia, fainting or losing consciousness. The pathophysiology, so the exact cause of hyperemesis is still unknown. There are several theories. The number one theory will be hormonal changes, and it's speculated that human chorionic gonadotropin, or HCG, levels peak in the first trimester, and this correlates with the onset of hyperemesis symptoms. Studies suggest that higher HCG concentrations are linked to hyperemesis. Estrogen also contributes to nausea and vomiting in pregnancy. With estrogen levels rising in early and decreasing later, it parallels the typical course of hyperemesis symptoms. Another theory is changes in GI system. So during pregnancy, elevated estrogen and progesterone relax the lower esophageal sphincter, and this increases the likelihood of gastroesophageal reflux that may also mimic symptoms of hyperemesis. Genetics. So women with family members who have experienced hyperemesis gravidarum as well have an increased risk of also experiencing hyperemesis during their pregnancies. There are also two genes that have been correlated to hyperemesis, and those genes are the GDF15 and the IGF-BP7 genes. Some of the risk factors include previous hyperemesis gravidarum, increased placenta mass in the setting of molar pregnancy or multiple gestation or being pregnant with multiples, women who experience nausea and vomiting outside of pregnancy due to consumption of estrogen-containing medication, history of Helicobacter pylori infection, or first-degree relatives like we talked about before. The criteria for diagnosis includes vomit that causes significant dehydration, evidence of ketonuria, electrolyte abnormalities, and weight loss of at least 5% of the patient's pre-pregnancy weight. Lab work for diagnosis include we would like to perform a urinalysis, which will show ketonuria in high specific gravity. This is due to the dehydration. We will want to order a CBC that may show electrolyte evaluation, especially for potassium levels. Hemoglobin and hematocrit levels, so elevation indicate hemoconcentration in the setting of dehydration. Severe dehydration markers such as elevated serum creatinine, blood urea nitrogen, and reduced glomerular filtration. We will also like to conduct other labs such as thyroid labs, lipase, liver function testing for evaluation of alternative diagnoses. Some of these differential diagnoses include gastroenteritis, hepatitis, ovarian torsion, diabetic ketoacidosis, drug toxicity, gestational trophoblastic disease, among others. So, as we know, diagnosis of hyperemesis is clinical and largely a diagnosis of exclusion. Some of the management for hyperemesis include rest, eat little and often, avoid triggers such as spicy foods or fried foods. Hydration is very important. If the liquid causes a pregnant woman to vomit, fruits are an option to keep hydrated. Recognize and avoid all the triggers such as odors or certain foods. Some evidence-based interventions, they are non-pharmacological measures. These are all guided by the American College of Obstetrics and Gynecology, or ACOG, for nausea and vomiting in pregnancy. The first one will be switching all prenatal vitamins to prenatal vitamins with folic acid supplementation. They can take ginger supplementation and see if that works, or acupressure wristbands. Some pharmacological therapies, they usually start with vitamin B6, about 10 to 25 milligrams by mouth 3 to 4 times a day, and doxylamine, about 12.5 milligrams by mouth 3 to 4 times a day. Second line medications include stramamine, Zofran, prochlorperazine, and promethazine. Some evidence-based interventions. In case of dehydration, IV fluid boluses or continuous infusion of normal saline, in addition to IV Reglan or Zofran or promethazine, has been shown to be helpful for severe cases of dehydration among pregnant women with hyperemesis. Severe refractory hyperemesis can also be treated with IV or intramuscular chlorpromazine or methylprednisolone. In very, very rare severe cases that causes progressive weight loss, jaundice, or persistent tachycardia, besides or despite all treatment, if this happens, termination of pregnancy may be offered if available in that state. Good education to provide to pregnancy women who might be experiencing hyperemesis is obviously educate the patients on the signs and symptoms of hyperemesis and how to distinguish it from just regular morning sickness. Recommend small, frequent, bland meals and avoid of all food triggers or strong smells. Stress the importance of hydration and recognizing the signs of dehydration. Advise the patient to take their daily multivitamins with folic acid. Connect women to support organizations like the HER Foundation or the Pregnancy Sickness Support for resources. Prevention strategies, like we talked about before, it's very important to take your prenatal vitamins, avoid all triggers, keep high protein snacks on hand, get plenty of rest, eat small, frequent meals, try cold foods and drinks to minimize smells, contact healthcare provider if symptoms worsen or if progressive weight loss, and obviously consider acupressure, and seek early medical advice. What are some red flags and when to seek support if the pregnant woman develops significant abdominal tenderness, pelvic tenderness, or vaginal bleeding? Should obviously prompt a workup or alternative diagnosis. Evaluate the woman presenting with hyperemesis for gestational trophoblastic disease and multiple gestation, as they may present with severe nausea and vomiting in first trimester of pregnancy. What are some complications? We'll start with maternal complications, and obviously that's vitamin deficiency, dehydration, malnutrition, Wernicke encephalopathy due to vitamin B1 deficiency, esophageal rupture secondary to very forceful vomiting, electrolyte imbalance, hypokalemia, depression, and anxiety. And fetal complications include low birth weight and premature birth. And these are my references.